giving one of the speeches today. But we have a very interesting program, I think. The speakers are experts in their area and have developed some very interesting techniques that I think you will find very interesting. My introductions will be minimalistic so that the speakers will have plenty of time to go through their presentation. I am required to ask you to turn off your cell phones or any beepers that you have so as not to disturb the symposium. Also, photography is not allowed. Of course, no smoking is allowed. And I don't know if there was anything else on that slide to inform you of. But what we'll hear today are a number of interesting talks on various types of micro, nanofluidics, point-of-care devices, total analysis type systems, which are coming to be more and more used, where you can do most of your sample prep and operations right on your microfluidic device. And so we'll hear about some of the developments in this area. So without further ado, as they say, let me introduce our first speaker. The topic is microfluidic capillary bioanalysis using miniaturized immunoaffinity and molecular imprinted polymer separations by Professor Thomas Carnes at the Virginia Commonwealth University in Richmond, Virginia. Tom? Hi there. That spotlight is pretty bright. Okay.
I'll just stick it in my pocket. Good afternoon, everyone. Thank you, Richard, for inviting me, and also thank the organizers of Pittsburgh Conference. I want to tell you about some of the work that we've done in my laboratory. It's essentially two PhD projects, Mike Peoples and Kumar Shah. They've now both graduated from my group, so this work is now published. It's a little bit old, and we're not doing it anymore, nothing similar to this anyway. But my laboratory is a little bit different environment. We're in a pharmacy school. It's a core lab setting. Most of what we do is in a regulatory environment, so we have to be very careful about having things validated according to guidances and so forth like that. So we have a couple of systems that work in that environment that I want to tell you about. I'm going to first describe the original basis for the system. We try to go as simple as possible, and then, as most of you experienced people know, you have to enter more complexity into the system to make it work. So there's going to be a couple of stories like that. The clinical need I want to talk about. We were collaborating with the NIH, and they had some needs that we were trying to address with these projects. The immunoaffinity instrument that we designed and built, the proof of principle with parathyroid hormone. These are the two analytes that we looked at, and C-reactive protein. And then the second project is involving molecularly imprinted polymers and microfluidics for assessing cancer risk, analyzing the nitrosamine NNAL in cigarette smokers. And this system was adapted for use with LCMS with no sample prep. Okay, as I said, we always start out simple, and two questions: how simple can you make it? How complex does it need to be? I think it's kind of exemplified here with the answer to this test question. It says find X, and the student says here it is. So sometimes the simplest answer might be very clever, but is often wrong. So in our case, it's a case of needing more complexity to make the system work. Can you hear me okay? Are we doing all right? Okay. So the first system that we developed involved direct capture immunoaffinity. And basically what that was, we were looking for a single step, very fast immunoassay that had no pre-sample prep. And so what we had was a specific antibody that was immobilized on a glass bead. And what you see here represents the components of a mixture. The little red dot here represents a fluorescent label. We use Lexaflor 647, and we were labeling a peptide, so the little squiggly line coming off of that represents a labeled peptide. These other things, the yellow and the blue, represent other proteins and components in the matrix because we're looking at blood plasma and there's a lot of other stuff in there. So what we were looking to do is to directly inject on a microfluidic capillary that had immobilized antibody into it, this complex mixture with labeled peptide. So hopefully what would happen would be the labeled peptide would be captured by the antibody, and then in the washing step all of this other stuff would get rinsed out. You would then have a step gradient, so you can adjust pH, you can add a cheotrope, or you can add an organic solvent, all of which would disrupt this antibody binding and liberate the labeled peptide. So you have all of the stuff that is unbound coming out in the front. This would represent your flow injectogram, I guess you would call it, or an immunoaffinity chromatogram. You would have all this unbound stuff coming out in the beginning, labeled it didn't have peptide attached to it, and other things that weren't bound. And then after the step gradient, say pH change, then you would have your antigen coming out in one peak. So this is a very simple system. Basically, it's a direct injection. You measure the response after the step gradient. It's been shown clearly, the whole idea of this was to do it very fast, and I think this figure from the literature represents it very well. Tokishi, in this publication in Electrophoresis, was basically showing that in the well plate format, you have an antigen here, and just the diffusion time and distance here is much different than if you have a packed capillary, which is what we're going to use in our system. The diffusion distance is much smaller. This system is designed to reach equilibrium, so typically they're incubated for half an hour, even sometimes overnight. Whereas this system, you force the antigen through, it is mixed as it's going through, and the diffusion distance is much less, so one would expect this process to occur much faster. It was also not designed to reach equilibrium. So this is the system that we built to do this chemistry that we're talking about. We had a commercial laser-induced fluorescence detector. This is a Zeta lift from Picometrics. It was sourced by a diode laser connected with a fiber optic. This is our capillary column here. We had a micro injector, and we did use one microchip in this system, which is a micro or nano mixing chip that we use to mix the solvents coming out of two syringe pumps. And of course, the system was controlled. Program for control and acquisition was written in LabVIEW. So that's basically the system. A close-up of the nano mixer. You can see the pencil tip to gauge the size, but basically this is just used to mix the gradient. It's from Upchurch, commercially available. It has two swept volumes. The one on the right is a 60 nanoliter volume. We found the 30 nanoliter volume was sufficient to mix our solvents, so you have the two in ports, the mixing branch channel here, and then the out port down here. We simply slurry packed the capillaries using vacuum and a micropipette. For the immunoaffinity columns, we used a PeakSil capillary. For the molecularly imprinted polymers, we used just peak tubing, 500 micrometer peak tubing. And the immunoaffinity solid phase was very difficult to pack, so it would take 2 to 3 hours. We'd have like a 50% failure rate on packing the columns. However, the molecularly imprinted polymers went very easily, 5 to 10 minutes, and virtually 100% success rate on packing them. And you see the column, the dime is here to scale size. The reason that we're doing this, and the reason that we needed to have it so fast, was that we were working with some colleagues at the NIH who basically needed to have intraoperative measurements done. This is showing a picture here. This is the parathyroid gland. It's very, very small. And when surgeons treat adenoma of the parathyroid gland, they really can't see the tumor. So what they do is they go in and they start excising the gland until the parathyroid hormone levels drop. So basically what they're doing is they're doing surgery on a patient and they're deciding when they're going to stop excising the tumor when they get a result back from the lab and it says the parathyroid hormone levels have dropped. Well, the problem is that if you send this down to the lab and you do it with a traditional method, the incubation time, it's going to take you almost an hour to get your results back. So they were looking for something that they could load onto a cart, do it on site, basically just make an injection in the operating room and get the result and decide whether or not they could close this patient up. So the whole idea was to avoid prolonged exposure to anesthesia and increase survivability rates in surgical patients. So when we first tried this system with parathyroid hormone in serum, and we filtered the serum, we're using a 1 to 10 dilution because otherwise the system would clog up if you had the full amount of protein in a serum sample. And the problem we had with it was non-specific background. If you look at this, the diluted serum, the purple chromatogram, this is basically background. This is just labeled blank. And if you look at a 4 microgram per mil parathyroid spiked, you do get a larger signal, but you've got a background signal of about 15-20%, which is not going to allow us to get down to the limit of quantification that we needed for the intraoperative surgery application. So what happens in this direct capture system is that you label the sample before you start. So you have a 50-50 mixture of diluted plasma and labeling reagent. And what happens is that you label a lot of the components in your plasma sample as well. And if those non-specifically bind to the stationary phase, as shown in this cartoon here, you basically have labeled matrix binding to the stationary phase, and then in that elution step, when you're decreasing the pH or adjusting the mobile phase, those then come off as labeled background. So the quantification limits are going to be limited for a technique like this. So again, back to the story of making things more complex. This is the simplest thing that we could design, but it has not worked for the application. Looking at the sources of nonspecific binding, we fabricated a dummy column with goat anti-rabbit that wouldn't bind to parathyroid hormone specifically. We looked at background just from the dye, background from the serum, background from parathyroid, and this is comparing it to the parathyroid column. So you have background from every source. It's about 2% here, 5% here, and total of 15% here. So the idea was to make the system a little bit more complex. But before we did, parathyroid hormone levels are in the picogram, the endogenous levels are in the picogram range. So we couldn't get down to the picogram range. So we decided to look at another application, which was C-reactive protein, that we'd have a better chance of quantifying the antigen in the physiologic range. And we were able to do that. You monitor C-reactive protein. It's a biomarker for macrophage activation. So if somebody's starting to get an infection, your CRP levels will increase. So they look at it for monitoring indwelling catheters, microdialysis probes, and things like that. So they were also interested in this. We were able to develop the CRP direct capture method. This is a calibration curve for it. This shows the calibration residuals throughout that range. We had a lower limit of quantitation of 500 nanograms per mil. The physiological normal is 2.5 micrograms per mil. So we were in the range, and we had good validation data that would pass the FDA guidance. So that was a successful application, although we could not do parathyroid hormone. So how do we make the system more complex to make it work at a lower level? Well, the idea was having this labeled background in there that was causing us problems. We figured if we could avoid doing that, then we could get lower background levels and lower our quantification limits. So what we did was we constructed a sandwich assay. And in the sandwich assay, what happens is that you pre-label a detection antibody. So you're not labeling your sample, and these matrix components should not be labeled. In this case, you take your antigen, you again specifically bind it to a solid phase antibody. The matrix may also get bound to the stationary phase, but remember it's not labeled, so you're not going to be able to see it, even if it does come out with the when you elute. So in a second step, this now makes it a two-step process. So before it was a one-step process, just basically an inject and read. Now it's inject your sample, inject your detection antibody, then read. So it's now a two-step process. With that detection antibody and the more complex system, you end up with this sandwich type. Your antigen is sandwiched between two antibodies, one with the label, one on the solid phase. And then you go through the same elution step, eluting your labeled antibody here, and this is what you detect. So we were indeed able to lower the background significantly here. You see this is 1 microgram per mil of C-reactive protein, and this is the background, much less than before. These blank plasma samples are immunoaffinity purified, so that's not endogenous levels of CRP. That's been taken out. This is our calibration plot. Again, we were able to reduce the lower limit of quantification to 50 nanograms per mil, or an order of magnitude. And again, we got acceptable residuals and acceptable precision and accuracy validation on this. They also wanted to look at CRP in cerebrospinal fluid. This is to detect meningitis, and the smaller the sample you can get, the better, because if you take a large sample of cerebrospinal fluid, it causes shock to the brain and gives you headaches. So they were looking at trying to do this in small amounts of cerebrospinal fluid. So we were able to adapt the method to cerebrospinal fluid, and we were able to come up with a 10 nanogram per mil detection limit, which was five-fold lower than the serum method. And again, it was validated in terms of its residuals, accuracy, and precision to acceptable ranges. And this is kind of an interesting study. We looked at serum versus cerebrospinal fluid and found that we got a much larger dynamic range in the spinal fluid. Spinal fluid has a lot less proteins in it. So not only was there an interference, but there is a matrix effect. There's also something in that sample interacting with the protein that is causing this limited range in the serum matrix. So interesting, both methods worked. We have done 185 injections with no noticeable loss of antibody. You understand that the idea is to elute these without damaging the antibodies, so you can reuse the same capillary over and over again. Okay, so this is the second project, the second PhD project. What we wanted to look at was tobacco-specific nitrosamines as an assessment of cancer risk. And this is going to be done with an LCMS detector, but we were trying to do it with no sample preparation. So basically just take a urine sample, inject it through one of these capillary columns, and then directly into the mass spectrometer and get your assessment of cancer risk. The cancer risk part is this is a carcinogen which is found in cigarette smoke. It is converted with P450 enzymes to this hydroxylation product here. So it's NNK to NNAL. And both of these are carcinogenic. The conversion here is about 99%, so it's almost all in this form of NNAL. It is further metabolized through glucuronide conjugation to these two compounds. Both N and O glucuronides are formed. These are detoxification pathways, meaning these are less carcinogenic and they're much easier eliminated from the body. So the cancer risk part is that if you have primarily this form, it's less dangerous than having this form. So if you look at individuals and if people are slow metabolizers in this pathway, then one would expect them to be high risk for developing cancer. So, okay, this is back to our simplest system again, starting out as simple as possible. This is our MIP-loaded capillary column here. In position A, we're basically just loading it with a water mobile phase, loading up the MIP with pure urine. And the idea was that you could load direct urine on there, and you could increase the volume of urine to get the detection limit that you wanted. So the idea was you could just keep loading it on and loading it on until you were able to detect as much as you needed to detect. The system is then switched with an elution. In this case, we're doing the elution with methanol, so the methanol then shoots it out of there, and it can be detected much like our first system. We needed to evaluate the capacity because since this is a microsystem, we're only using 1 milligram of packing material. We wanted to make sure we had the binding capacity for this NNAL. And so we looked at response versus concentration and the Bmax from modeling this curve. If you convert that to concentration, we got 1.5 micrograms. So we have plenty of capacity. We're going to be detecting picograms of NNAL, and we've got microgram capacity on this microcolumn. So we're fine there. Second step was to look at selectivity. So what you see here is a direct injection of urine. So this is the urine matrix. This is the NNAL peak from the matrix spiked in there. And this is the blank urine. So basically you're looking at, this is just a pressure pulse. There's basically no background. So very, very encouraging initial results. Here comes the problem. This idea of loading more sample. If you look at this, these are neat solutions of NNAL, so you add more volume, you get a greater response. If you do the same thing in the urine matrix, you basically keep the same response. So although we didn't have any interferences, we had something going on here. Either something was interfering with our binding sites, or we had ion suppression in the mass spectrometer, so we had to sort this out. First thing we looked at was ion suppression, and this is a post-column infusion experiment where basically you're looking at infused NNAL in this first mass spectrum. The second one is an injection of the matrix. So what you see here is a huge suppression peak around the area of elution of NNAL, which is basically here. So our problem was ion suppression. We looked at adjusting the chromatography on the front end, making the wash solution stronger. This is the matrix effect that we saw. This is the NNAL response. As you see, we start losing NNAL immediately, and it does nothing to the matrix. So you can't wash it off, basically. Can you leave it on? Can you wash off NaAl and leave it on? In other words, can you weaken the elution solvent? So that we did that experiment, and as you see at about 20% you start losing NaAl, but you still see the same amount of matrix. So that was unsuccessful as well. So the answer is introduce more complexity into the system. And that's what we ended up doing. We thought that since NaAl was more soluble in methanol than these matrix components that were causing the ion suppression, that we could leave them behind on a reverse phase column. So that's essentially what we did. We put a HPLC reverse phase column in line here, and then made the system more complex with a pump to control that. So in position A, again, you're loading the MIP column. In position B, you're basically eluting it off of the MIP and then onto this HPLC column. And if you look at the proportions, it's going to be about 25% methanol. So we were successful in leaving that ion suppression behind. You see the ion suppression is much smaller here, and it's small enough to where the peak is now resolved from the suppression. So that was successful. We optimized this by looking at signal to noise in the blue versus resolution in the purple, and we figured optimal was about 200 microliters of injection volume. In other words, that's the most you can put on without those two peaks running together and starting to see suppression. We looked at some ruggedness testing. This is different packings of the same material. This is different lots of material. You see it can be done pretty consistently. There was some variable in the manufacturer, from the manufacturer, lot to lot. This is the accuracy and precision validation results within run and inter-run down to 20 picograms per mil. And you see that the validation data is all very good and very tight within the FDA guidance, which was our target. Wide linear range, 20 to 2,500 picograms per mil, and lower limit of quantifications of 20, as I said. Selective in 6 lots, all of that stuff that's required by FDA. We compared our microfluidic method to a published offline extraction method, and this is a table showing that. We basically did direction injection after pH adjustment, where there was multiple steps here. Sample preparation time 8 to 10 hours. No sample preparation time in ours. Sample volume 5 mils, 20 microliters for ours. This used a 25 milligram bed in an AL MIP. It's basically an extraction cartridge. What we did was we took those extraction cartridges, unloaded them, and used 25 milligrams of the 25 milligram bed for packing our capillary column. Now, the impact of this is pretty significant. These are 25 milligrams and not reusable. You throw them away. Over here, you've got 1 milligram that we've done 300 injections on, so it is reusable. So essentially, we get 7,500 analyses out of one extraction cartridge. They have a solvent evaporation step. We had no loss, no potential loss due to evaporation. Looking at smokers' urine, we looked at 43 smokers. This is a PCA analysis with the loading features being NaAl, glucuronide, and the ratio. And you see principal components analysis basically came up with 3 groupings. One group that had high free NaAl and a low ratio of the glucuronide, which means that these would be high risk for developing cancer. You have the normal population in the middles, and you'll also have a population that is low risk. These yellows here were the ones that were below the limit of quantification. Probably hadn't been smoking recently. Okay, so in summary, the direct capture method does work. It does not require secondary labeled reagents. You may have to do some extra steps to reduce this background that we talked about. The sandwich immunoaffinity is not as susceptible to these backgrounds, but you do have to prepare an additional reagent, and there's another analytical step. The NNAL determination was successful using LCMS, well validated. The smoker's urine showed definite patterns, and they may be related to cancer risks. As preliminary studies, we don't consider 43 smokers to be enough to make these conclusions, but there are patterns emerging. So I'll be happy to answer your questions if you have any. Thank you very much for your attention.
Thank you, Tom. Very interesting.